As you all know, this program is purely for the postgraduates. The main aim of these online classrooms are to present a case in front of a mentor and an external faculty so that they will get a rehearsal for case presentation for their examination. And today, it is a 22nd module what we are having today. And Dr. Elsa Maria Kurivila from Amala Institute of Medical Sciences. She is a junior resident there. She will be presenting a case. And Dr. Lediga, Professor of Ophthalmology, again from Amala Institute of Medical Science, Thrissur, will be the mentor. And on behalf of scientific committee, I welcome Dr. Vishal R. Raval, consultant vitreoretinal diseases and ocular oncology from LB Prasad Eye Institute, Hyderabad. Welcome, sir. Welcome to this program.
Thank you, sir.
Dr. Vishal Raval is the consultant from LB Prasad Eye Institute, Hyderabad, and he has published widely in the peer-reviewed journals and presented at various conferences. His areas of clinical interest are in the field of vitreoretinal diseases such as diabetic retinopathy, retinal detachment, and ocular oncology, including management of intraocular tumors such as retinoblastoma, choroidal melanoma, and various other retinal and choroidal tumors. The research front, he is keen on translational animal research in the field of ocular oncology, particularly retinoblastoma. With these few words, I hand over the program to Dr. Lediga. Over to you, Dr. Lediga.
Thank you, Dr. Baston. First of all, let me thank KSOS and the scientific committee in particular for having given us this opportunity and for having given my resident this opportunity to learn from such a very well accomplished external faculty as well. Thank you so much. And now, Dr. Elsa, can you please start your presentation and start sharing the screen?
Okay. So I'll be presenting the case of ophthalmic manifestation of tuberous sclerosis. So the presenting complaint, it's an 11-year-old male child who, with a non-diagnosis of tuberous sclerosis complex, who presented to our OPD for routine evaluation of retinal astrocytomas, and there is no associated visual symptoms. So coming to the past history, the child initially presented to our OPD at the age of 4 years with multiple reddish-brown papules below both lower lids and eyelids and cheeks. And retinal examination revealed small, well circumscribed translucent lesions in both eyes, suggestive of early retinal astrocytomas. And the child was then referred to pediatrician for systemic workup, and a thorough evaluation by pediatricians revealed systemic hypertension, then associated dermatological finding, which include facial adenoma sebaceum and Ashley macule over trunk, and bilateral renal angiomyolipomas, which was confirmed by abdominal ultrasonography, then multiple cardiac rhabdomyomas in both left and right ventricles, which was confirmed by echocardiography, and MRI brain showed features of cortical tubers and subependymal nodules. And all these, there are four major criteria. And since the child was then diagnosed with tuberous sclerosis complex and is on follow-up since then. Now, coming to his birth history, he was delivered by full-term normal vaginal delivery with 3 kilograms of birth weight, and the baby cried soon after birth, and other antenatal and postnatal history were uneventful, and infantile seizure was diagnosed 2 months after his birth. And coming to family history, though there was no history of parental consanguinity, he's the only child, and there are no history of any similar complaints in either parents or other close relatives. Coming to his personal history, developmental age history, it's adequate for age, and he has an average scholastic performance. And speech started later than a normal child, and his immunization history is immunized as per age, and other personal histories within normal limits. Coming to general examination, the patient is conscious, cooperative, well-oriented to time, place, person. His height is 140 centimeter and weight is 36 kilograms, which is normal for the age. And vitals were within normal limits. And head-to-toe examination revealed adenoma sebaceum over face and both elbows and ash leaf macule over trunk. So this is the adenoma sebaceum over his face and nose and ash leaf macule over the trunk region. Then coming to ocular examination, his orthophoric, there is no evidence of face turn, head tilt, or chin lift. And then his distant vision and near vision in both eyes are 6 in both eyes, and near vision is N6 in both eyes, and his anterior segment is within normal limits, and the usual features of palpebral lesions, poliosis, in lids and nexa is not present in this child, and there is no features of any iris hamartomas or coloboma, which are usually seen in tuberous sclerosis, but it is absent in this child. And gonioscopy was done for this child and revealed open angles and dilated fundus examination of right eye. The media is clear, vitreous appears to be normal. Then disc is normal in size, shape, and color. Disc margins well defined with cup-disc ratio of zero point 0.5 and a healthy NRR. And vessels appear to be normal with an AV ratio of 2:3, and foveal reflex was present. And then there is an elongated, slightly raised translucent lesion longitudinally with 1.5 disc diameter in length longitudinally with distinct borders at 4 o'clock to 5 o'clock position along the infranasal arcade. And similarly, multiple small circular, well circumscribed, flat translucent lesions were seen at 1 o'clock, 3 o'clock, and 9 o'clock positions. And there is no evidence of any retinal, any calcification, hemorrhage, exudation, neovascularization, traction, subretinal fluid, or retinal detachment in right eye. Coming to the dilated fundus examination of left eye, media is clear with disc which is normal in size, shape, and color with well-defined disc margins and CD ratio of 0.5 with healthy NRR. Vessels appear to be normal with AV ratio of 2:3. Foveal reflex was present and elongated translucent slightly raised lesion with irregular borders of 2 disc diameter length longitudinally spanning 4 o'clock to 6 o'clock position along the infratemporal arcade, obscuring the vessel with associated dot hemorrhage was seen, and multiple small circular, well circumscribed, flat translucent lesions at 4, 6, and 10 o'clock positions were also noted. And here also there is no evidence of any calcification, hemorrhage, exudation, neovascularization, traction, subretinal fluid, and detachment. And he was followed up after 2 weeks and found that the hemorrhage resolved spontaneously.
Okay,
And we
Elsa,
did the
wait 1 second. Okay, so I think we don't need to rush. I think first important thing, you need to speak little bit slowly.
okay, sir.
There is no rush here. There is no time limit that you need to complete the presentation in 2 minutes, 5 minutes, 7 minutes, as it happens for any podium presentation or for any conference. You are presenting a case to an examiner, external examiner, especially. So you want to be a little bit slow. Take the examiner along with you. Now let us summarize the case till now what you have presented. So you have a young child who has been already diagnosed to have tuberous sclerosis complex, and he has been referred to an ophthalmology hospital to look for any, especially ocular manifestations of tuberous sclerosis. So before
Yes.
we go on to the ophthalmic manifestation, can you tell me something about tuberous sclerosis? What kind of disorder it is? What are the genes involved? And why do you see it is a multi-system disorder in terms of its pathogenesis?
So tuberous sclerosis actually belongs to the group of phacomatous conditions, and the
So
actually there are
what do you mean by phacomatous?
that means there is a, block or a lesion there, and the chromosomes involved are chromosome 9 and chromosome 16. So the chromosomes, that is tuberous sclerosis complex 1 and tuberous sclerosis complex 2 are there. So in chromosome 9, tuberous sclerosis 1 is involved, and in chromosome 16, tuberous sclerosis 2 is involved.
Okay.
And hello?
What kind of hereditary it is? Autosomal dominant, autosomal recessive? What kind of?
Autosomal dominance, sir.
Okay, so what do you mean by autosomal dominant? So if you want to make a pedigree chart, if you go to this patient, so if you look at the pedigree chart in your case, go back to the family history. Yeah, the pedigree drawing what you have made. Yes. So can you explain me what do you understand by this pedigree chart?
Actually, here in this pedigree chart, the parents are not involved. In autosomal dominant, the parents will be involved.
Okay.
Generations will be involved.
So whether the parents are involved or they might be the carrier. So how will you identify one of the parent is carrier or not? What you will do?
So genetic study. So
Okay, so what genetic testing you want to do? So here in your case, you have a proband who is diagnosed to have tuberous sclerosis on the basis of different criterias, as you have mentioned. So can you enumerate and tell me what are the major criterias and minor criterias to confirm a diagnosis of tuberous sclerosis in a proband or in a child?
So the major criteria include features of retinal astrocytomas can be seen. Then actually the other features include there will be hypomelanotic macules, but it should be more than 3 and at least more than 5 millimeter in diameter. Then there should be angiofibromas and ungual fibromas, which should be more than 2. Then Sjagren patch. Then as said earlier, multiple retinal astrocytomas.
Where do you see chagrin patch?
Leathery appearance over trunk and also
Sorry,
leathery appearance over trunk region.
yeah, on the lumbosacral area.
Yes, sir.
Okay, and anything else? What are
Then
hypopigmented spots you see? What they
yes,
are called?
actually hypomelanotic macules. That is actually macules should be seen, but in
Okay,
major criteria it should be more than 3 with a diameter of at least 5 millimeter should be there.
okay. Anything else? Any
Then
other
there
any
should
other
be
organs?
sir.
Any other organ involvement?
Yes, there should be subependymal nodules in brain, then subependymal giant cell astrocytomas, then renal angiomyolipomas should be there, then cardiac rhabdomyomas should be there. So
Anything
that is
else?
a major criteria. So if more than 2 is fitting, then we can call it a tuberous sclerosis complex. Uh,
No,
then minor.
still
Hello.
one couple of organs still are left. So what do you see in case of kidney or renal?
Renal angiomyolipomas will be the then lymphangiomyomatosis. Renal angiomyolipomas can be there. Then um, uh,
Pancreas?
uh, pancreas. I don't know, sir.
So again, so it is very, very important because you as a ophthalmologist sometimes might be the first person to diagnose a case of tuberous sclerosis based on the retinal findings you might be seeing. So when you refer them to a pediatrician or a endocrinologist, you should be aware of what all things you should be looking in a particular child when you're referring them for a screening for tuberous sclerosis. So as you correctly mentioned, the major and minor criteria, it is very, very important that you see, at least from the external point of view, from the torchlight examination or from your general examination, you look for the specific features such as chagrin patch, hypopigmented spots such as hash leaf spots, papules, subpendamas. I think these are very, very clinically visible on your general examination. Yes, for your multi-system involvement, you need to do for echocardiography, USG ultrasonography, and MRI brain, particularly to look for subependymal nodules as well as subcortical tubers, which are especially seen in the cerebellar region. Okay, so in this case, as this child was already diagnosed to have tuberous sclerosis, and now the child has been referred for an ophthalmological evaluation. So, what all things you are going to evaluate when this child comes to you in the clinic for an ophthalmology screening, especially when the diagnosis is already established as a case of tuberous sclerosis?
So there can be anterior segment features which include palpebral angiofibromas can be seen in palpebral
Very
both
good.
lids. Hello,
Yes,
sir.
yes, good.
Palpebral angiofibromas can be seen. Then on anterior segment also there can be there is iris hamartomas can be seen. Then colobomas
So,
in the iris,
what other phacoematosis condition you see iris hematomas?
neurofibromatosis we can see leash nodules.
So, which type of neurofibromatosis?
Type 1.
Okay. And what is type 2 neurofibromatosis?
There will be associated schwannoma can be seen.
Where do you see schwannomas?
Acoustic schwannomas
Acoustic
can.
schwannomas. Very good. Okay. So, in the eye from the anterior to posterior segment was to mention about the eyelid lesions. Second, you mentioned about the iris. Anything else in the anterior segment?
So there can be associated, I mean, lens colobomas can be seen, and
Okay.
also strabismus can also be seen. In
Okay. That is not an kind of what you can say classical finding for tuberous sclerosis. Anything else? You did gonioscopy also. Why did you gonioscopy?
So to see if there is any neovascularization of the iris, neovascularization of the angle can be in certain cases neovascularization can be seen, sir.
So that is in the late case. Why,
Yes.
why do you do gonioscopy in any case? What do you want to look? Are you looking only for neovascularization or something else you
No,
are
sir.
looking?
To see whether the angles are open or not, then
So,
whether the trabecular meshwork, whether the pigmentation is normal,
so
then
what
to
you
see.
want to look is there is an association with glaucoma, because most of the phacomatoses you look at, whether it is tuberous sclerosis, whether it is Sturge-Weber syndrome, or whether it is neurofibromatosis, they always have a secondary association with glaucoma. Most of the time it is open angle glaucoma, but as you correctly mentioned, if there is a pigmentation, then it might be associated with angle closure glaucomas. So eyelid is done, iris is done, glaucoma is done. Then anything else?
Uh, so then intraocular pressure measurement,
Okay, that is glaucoma. Okay, fine. Posterior segment.
posterior segment, that is retinal astrocytic hamartomas. We are
Okay.
looking for, and also there can be actually colobomas also usually in the infranasal quadrant.
So let us deal one by one. So first you told about retinal astrocytic hematoma. So how do they clinically visible when you do your fundus examination?
So there are actually three types of retinal astrocytic hematomas. That is, the first type is flat translucent lesions,
Okay.
well
Where are
circumscribed.
they visible? Which part of the fundus? They're seen at the posterior pole, they are seen at the equator, they are seen at the periphery, they are seen on the optic disc.
It can be seen at the optic disc. It can be seen at the posterior pole and along the vessel, along the arcades also it can be seen.
Okay. So that is type 1. That is you said about a flat translucent.
Yes, sir.
Okay. Type 2.
Type 2 can be multinodular type with associated calcification also can be seen in long-term cases of tuberous sclerosis.
So
Multinodular type. It can be actually mulberry type or mulberry type lesions can be seen with associated calcification.
So, what all other differential diagnosis will come to your mind when you see this kind of flat translucent lesion with some kind of calcium specks within that? So, what all the other things you will think of or rule out before you confirm this diagnosis to a retinal astrocytic hematoma?
The other differential diagnosis of achomatosis, like neurofibromatosis, then
So,
uh,
do in neurofibromatosis you see retinal astrocytic hematomas?
capillary hemangiomas can be seen.
No, I'm saying a specific finding that you see whitish retinal astrocytic hematoma as you clearly described. What all other lesions will resemble this kind of appearance, and you want to rule out particularly in a child when you see this kind of lesion?
Uh, Whitish lesions can be tumor conditions like retinoblastoma, Coats disease. Then
Okay,
in von Hippel-Lindau syndromes, but then in von Hippel-Lindau there will be dilated and feeder vessels will be seen.
yes, so let us go one by one. So retinoblastoma, I think that is very important. As you correctly mentioned, that is the most common differential diagnosis for retinal astrocytic hematoma. Again, both are seen in the kind of children less than 10 years of age. Both clinically visible will look as translucent elevated retinal lesion with some amount of calcium. But then how do you differentiate between the two, between a retinal astrocytic hematoma and retinoblastoma on the basis of appearance? Is there specific feature what you will say will be able to distinguish one from the another?
So there will be evidence of leukocoria in retinoblastoma.
So that
Then,
leukocoria will be seen in case of tuberous sclerosis or retinal astrocytic hematoma. Why do you see leukocoria?
that is because of either the detached retina or the lesion can be seen on shining through torchlight.
So the lesion, if the lesion is near the macula or near the optic disc, it will show leukocoria in tuberous sclerosis also, or in retinal astrocytic hematoma also. Anything else? So basic important differential what you want to look is the color and the appearance of the lesion. So if you look at the calcium, which is usually seen in retinoblastoma, it is usually chalky white in color as compared to calcium, which is seen in case of retinal astrocytic hematoma. It is bright yellow in color. Second, the lesions, what you see in case of retinal astrocytic hematoma, they are kind of semi-transparent or translucent as compared to in case of retinoblastoma, which might be fish flesh in appearance. And third, very, very important differential or feature, what help you differentiate one from the another. In case of tuberous sclerosis or retinal astrocytic hematoma, the lesion will not have any surrounding SRF or surrounding retinal pigment epithelial atrophy. As in case of retinal blastoma, you will have surrounding SRF, exudative RD, and other features such as tumor vascularity, everything. So that will be absent in case of retinal astrocytic hematoma. So that will help you to differentiate one from the another. Okay. Anything else you see in the fundus evaluation for a case of tuberous sclerosis?
Tuberous sclerosis. Then fundus, it can be seen actually in optic disc. There can be astrocytomas. Then in subependymal giant cell astrocytomas, if they block the foramen of Monroe, it can lead to obstructive hydrocephalus, and that can lead to papilledema.
Okay, so that is all secondary or sequelae of the primary pathology in the brain. That's why you are seeing the optic nerve involvement and you see papillary edema, optic disc hyperemia, and all kind of. I am seeing the finding which is very specific to the retina. So one you told retinal astrocytic hematoma. Anything else which has been described very recently by Shields? So the homework for you, you need to find out and let us know what is the second common retinal finding, what you see other than retinal astrocytic hematoma in the case of tuberous sclerosis.
So retinal achromatic patches can be
Yes,
seen.
very good. So that is retinal achromatic patch. So what is the meaning of that? And where do
That
you
is
see that?
RP pigment anomalies.
Yes, so these are usually hypopigmented lesions, which are very small, 1 to 2 millimeter in size, and usually seen along the course of the blood vessel, particularly at the mid equator or in the periphery. So these are also one of the findings which have been established, particularly in case of tuberous sclerosis, when you look for retinal finding or fundus findings in case of already diagnosed case of tuberous sclerosis. So the two important features, particularly from the ophthalmology point of view, is to look at the retinal astrocytic hematoma and second is retinal achromic patch. Okay, you made the diagnosis, you saw these lesions. Now what? Now what you are going to do?
So now, sir, I'll investigate. We'll do an OCT scan
Why do you want to do OCT?
because we want to see the type of lesion. So usually it will be a hyperreflective lesion, a dome-shaped
So
lesion, which
go
will.
come back to your case and show me the OCT, what you have done.
So, so
Yes.
this is the OCT
Okay.
scan through the lesion in the left eye. So it shows a well-defined hyperreflective dome-shaped thickening noted in the inner retinal layers,
Okay.
and there is associated shadowing, but there are no associated cyst or any subretinal fluid.
So what are different OCT subtypes of retinal astrocytic hematoma, you know?
OCT subtypes, it can be in type 2 multinodular. There can be this dome-shaped elevation with associated cyst formation also, and cyst formation can actually the cavitation can actually is suggestive of calcifications.
So the again homework for you. There is a recent classification by Francisco Picci et al. From Cleveland Clinic, Dubai, and they have subclassified retinal astrocytic hematoma on the basis of OCT findings in type 1, 2, 3, and 4. So again, read that paper is published in Retina Journal in 2016, and that is very recent classification on based of OCT findings for retinal astrocytic hematoma. So type 1, type 2, type 3, type 4. It is very, very important and that you should be knowing, particularly when you go for any kind of case presentation on retinal astrocytic hematoma. Okay, any other findings or any other imaging you want to do?
So then we can do actually ultrasound B scan can be done in fundus autofluorescence and FFA we can do.
So what you will see on B scan ultrasonography, what you will see?
Hyperechoic shadowing can be seen. That is, there will be an acoustic solid tumor with a hyperechoic shadow can be seen.
And on A scan, what you will see?
Yes.
So that in B scan ultrasonography, you have any photo of B scan? No.
No, sir.
Okay, so you might have seen the ultrasonography picture, particularly of B scan. So always in the lowermost or the bottom part of the picture, you have the spikes. kind of waves which goes up and down. So that is the A scan spike. So when you pass the vector of your B scan mode through the lesion, you will see a 100% spike, which is corroborating with your lesion, which is in the vitreous cavity or in the retinal layers. And that is because of the calcium which is present within the lesion. So any lesion which has calcium, it will show 100% spike. So that's what you will see in the case of retinal astrocytic hematoma, especially if it is a calcified lesion, where you will see hyperechoic lesion in the retinal layers with 100% spike on A scan. On autofluorescence, what you will see?
Fundus autofluorescence, that is, if there is no calcification, then there will be a reduced physiological background fluorescence. But if there is a calcification, then there will be it will be hyperfluorescent, sir. If there is
Hyper autofluorescence.
yes, sir.
Okay.
It is
Fluorescein
autofluorescence.
angiography, what you will see?
There will be there can be early blockage of background choroidal fluorescence,
Okay.
and then lately can be seen, sir, hyperfluorescent, which it will gradually increase in intensity and extent the size.
Okay. So for this case, you did all the imaging, you did all the workup, and you came to a final diagnosis of retinal astrocytic hematoma, bilateral in both the eyes, with tuberous sclerosis complex as the systemic disorder. So now what is the next step as ophthalmologist? What you're going to do? What you're
Uh,
going to tell the parents?
so we will actually retinal astrocytic hematomas. They are actually benign lesions which will only gradually increase in size. That is not a much progressive lesion. Uh, so we'll keep them on follow up, a yearly follow up.
And anything
And
else?
if there is, uh, then that is if there is any visual disturbance and all, we'll ask them to
So
come for.
what will lead to visual disturbance?
So
What
if there is
complications
any,
you are looking at?
that is whether there are any subretinal fluid, retinal traction, or retinal detachment.
So very rarely it might be associated with vitreous hemorrhage, some kind of choroidal neovascular membrane, that is CNVM, or sometimes vascular occlusion if it is very close to a larger retinal blood vessel. So these are a few sequelae which can happen very, very rarely, but yes, it can be associated with tuberous sclerosis, especially if it is a tuberous sclerosis complex and it is a large retinal astrocytic hematoma.
So,
Okay, so go back to your case and tell me what you did in the end for this case.
uh, so we did a visual field was
Okay.
also.
Good.
Uh,
As a documentation at the baseline, you need to do visual field. If there is an optic nerve involvement or the retinal astrocytic hematoma is in the parapapillary or the juxtapapillary area, you should do a visual field also. Good.
so then we actually then we came with the diagnosis tuberous sclerosis complex. So I've highlighted the major criteria. So more than two actually suggest major criteria suggest it is a tuberous sclerosis complex. And then we did a genetic study,
Okay.
but then the genetic study actually showed that there is no pathogenic variant. That is, no phenotypes were detected, but actually in literature, in 10 to 25 percentage of the cases, actually that is it is shown that there is no mutation identified by conventional genetic testing, but that a normal test, it does not exclude tuberous sclerosis complex or will not have any effect on the clinical diagnostic criteria to diagnose tuberous
So
sclerosis
what
complex.
kind of genetic testing you have done? It is targeted testing only for TSC mutation, or you have done whole exome sequencing? What was the testing done?
Actually, targeted testing was done.
Yeah, so that's where the issue is, because you were suspecting it to be tuberous sclerosis, so you have looked only for two genes, that is TS1 and TS2, and you have done very targeted testing. So there might be associated other factors involved, or neurofibrotic NF1, which might be involved, particularly in this case. So I would say yes, the 99% of cases, whenever you have all this systemic involvement and the IUC, I think invariably you will see the genetic testing will come positive for tuberous sclerosis complex as TS1, TS1 or 2 mutation testing, you will be positive. But if it comes negative, I think that is very, very important that you don't stop at that particular test and go for whole exome sequencing or look for other targeted mutation which can be associated with the tuberous sclerosis. So it is very, very important. You should not stop at this if you don't find the mutation for tuberous sclerosis in this particular patient.
Okay, sir.
Okay, anything else?
No, sir.
Okay,
This is
so what all treatment options you know for retinal astrocytic hematoma?
there can be the conventional general systemic treatment. That is, for seizures, we can give vigabatrin. Then mTOR inhibitors are there. Actually, the pathogenesis of tuberous sclerosis, there will be activation of mTOR receptors, and then that can lead to cellular proliferation and vascular endothelial growth factor proliferation, which can lead to tumor. So the mTOR inhibitors like sacrolimus, then interferon gamma can be given, can be tried. Then, in case of any macular edema or traction, we can actually give intravitreal anti-VEGF agents. And laser therapy can also be given in case of persistent macular edema. And coming to the surgical side, if there is an exudative retinal detachment, we can do actually pars plana vitrectomy and all.
Yeah, I think retinal detachment of vitreous hemorrhage, they are very, very rare complications. But I think from your understanding, I think it is very, very important that in most of the cases, observation is warranted. Usually they don't progress or they don't kind of metastasize or they don't kind of transform from benign lesion into malignant lesion, which is very, very, very unlikely. Usually these are benign lesions and they usually remain the same. Sometimes it might increase in size and it might cause some visual disturbance, but then you have to take into consideration whether it is an kind of acquired retinal astrocytoma or it is a kind of spectrum of your tuberous sclerosis complex. If it is bilateral multifocal retinal astrocytic hematoma, invariably 50 to 80, 70% of chances there is underlying tuberous sclerosis association is there. So you need to do all your testing to find out the other multi-system involvement is there or not. In terms of treatment, yes, for your renal angiomyolipomas as well as for your subependymal cortical tumors, the treatment of choice, what is established now, it is your mTOR inhibitors, as you correctly mentioned. And the most common drug what we use is either your sirolimus or rapamycin. And these two, both of the drugs, whenever they have been given for renal or brain involvement, have invariably shown the effect in the eye also. So whenever they gave for eye or brain and the patient had some kind of small lesion in the eye, that has also showed kind of regression. But the when to stop the drug, that is no standard of protocol recommended guideline. So usually they give it for 1 to 2 years and see the response, how the brain or the renal angiomyolipomas are kind of responding to treatment. But from the ocular point of view, I think as an ophthalmologist, our role doesn't kind of stop to diagnose a case of retinal astrocytic hematoma. As I told you, you might be the first person to diagnose a case of retinal astrocytic hematoma, and it is very, very important that you understand its multi-system involvement. Do a good referral to pediatrician or your neurointerventional radiologist to look for other multi-system involvement, and that's where your kind of job is very important. So a multidisciplinary approach should be there in your mind whenever you are kind of looking at a case of identified tuberous sclerosis, or you are looking at a first case of retinal astrocytic hematoma, and you might be the first person to referring to your other subspecialty clinics. Other than that, I think most of the points we have covered in terms of your diagnosis, imaging, as well as treatment. Over to you, Dr. Latika. You are muted, madam. Can you unmute, madam?
Yeah. So thank you so much for highlighting, especially highlighting the differences between the retinoblastoma growth and the astrocytoma. So many fine points there. We all benefited. Thank you very much. I'm just concerned about this child a bit because of the retinal hemorrhages that we had seen. Actually, this child has been under follow for the past 6 years, and only last month we noted some small retinal hemorrhages near one of the astrocytomas. So that was slightly concerning because this child is now in the pubertal stage also. Do you think that, I mean, is it first a sort of ominous sign? What is your experience like? Why this retinal hemorrhages should occur like that without any neovascularization or any other increase in size or anything? No other features were there. So that I could not really
Yes.
understand why the hemorrhages were there.
It is
Thankfully, it
very
resolved. Uh,
it is very unusual to have retinal hemorrhages associated with retinal astrocytic hematoma. Usually, you might see a small speck of heme might be kind of adjacent to the border of the lesion if it is kind of growing or it is progressing. But having multiple hemorrhages in the retinal structure, I think it is very, very unlikely. It might be just a coincidental finding that this child might have some specific retinal hemorrhages. So it doesn't fall into any kind of sequelae or complication of the disease process what you have, especially in this child.
Okay, sir. Another thing is regarding these mTOR inhibitors. The ophthalmologists, as ophthalmologists, should we be starting them, or should we, for the retinal lesions, will the pediatrician start for retinal lesions alone? So do you start it, or do you recommend it to the pediatrician to start if you find that the astrocytomas are growing?
Yeah, again, so if we have a serial documentation, and when you are already described and shown that the lesion is progressing in size in terms of its basal diameter or the thickness, or there is a presence of subretinal fluid, then you know this is a growing lesion. And whenever it is growing lesion, invariably if it is near the parapapillary area or in the fovea or the macular area, you're always worried about the visual kind of disorganization or visual fluid might come into the fovea or the macula, and you might feel the visual acuity is going down. So in that account, I think it's always good to consult your pediatrician, because this sirolimus or rapamycin usually we give for your other autoimmune diseases, especially in children, like rheumatoid arthritis, JRA, where they usually give this immunosuppressant. So yes, because Ayurveda Prasad is a multi kind of specialty hospital, so we have all the pediatrician or the rheumatologist in house, so they usually help us to start the children on kind of mTOR inhibitors. But again, the important point, what I told, even if we start, we might see the reduction in the size of the lesion, but then how long to continue these drugs, it is kind of, there is no standard of care or protocol or guidelines when we should stop this, because there are some side effects also associated with mTOR inhibitors, especially in this children age group. So you need to take into that account also before we start on this mTOR inhibitors for retinal astrocytic hematoma especially. But from the brain point of view or from renal point of view, if the pediatrician feels, I think they are the usually ones who usually starts.
So, conventionally, we used to be taught that if the astrocytomas are enlarging, lasers are the one choice that the ophthalmologist has. But now, this medical therapy, is it an adjunct to that, or is it an alternative to that?
No, no.
And
So
do we still need
again,
to laser?
sorry, come again, madam. I didn't understand last question.
Do we still need to laser astrocytoma that is growing, or is this medical therapy alone suffice to bring down the size of the lesion?
So if the lesion is close to the fovea or the parapapillary area, again the laser is detrimental, again because it is going to cause harm to the vision. So in that cases, your medical treatment should be the first line what you should be starting on. But if it is in the periphery, in the equator, then your routine laser or your transpupillary thermotherapy should take care of the growing astrocytoma.
Okay, sir. So, if you are using the green laser, what are the parameters are just what are the parameters that generally
So
preferred?
we don't use green laser for, especially for the benign lesions. We use transpupillary thermotherapy. So that is a
Okay.
diode laser. So that is a long duration with a big spot size, that is 2 to 2.5 millimeter spot size. And the photocoagulation which happens, it is at a low threshold around 60 to 65 degrees centigrade.
Okay, sir. So the regarding the anti-VEGF therapy, it is indicated only if there is a neovascularization
Neovascular
or
membrane.
macular edema, right, sir?
Yes,
So,
again, if you do a laser transpupillary thermotherapy, it can be used as an adjunct treatment for your subretinal fluid in the fovea or in the macula or insistent macular edema. In as adjunct treatment you do, but it is not as a single on agent for treatment of astrocytic hematoma. It doesn't have any role. There might be some case reports here and there, but then again, it is just a case report. You can't establish that as the standard of care for treatment of retinal astrocytic hematoma.
okay, sir. So these were a few doubts I had regarding this because
They're
of
all
the.
valid and genuine questions, madam.
So, I mean, it is not often that we get to interact with such experts. It was a very good learning experience
My pleasure.
for both my student and myself. Thank you so much for sharing your wealth of knowledge
Sure,
with
madam.
us. So, Dr. Bastin.
It was like good learning points. Like it's a rare cases and
Yes.
good to hear from people like you who are like always do research in this field.
Thank you, sir.
For the postgraduates, I think such cases also used to come for the examination, right?
Yeah, so usually they are kind of short cases from the posterior segment point of view, because there's very few findings what you see in case of tuberous sclerosis. So it is a kind of spot diagnosis you see, and yes, the Viva can go from genetic, from the other major minor criteria for tuberous sclerosis, and the treatment what we kind of recently kind of discussed right now.
So you can go and read the points.
Yes.
Yeah, I think the OCT classification you should be reading, Elsa. It is very, very important because that's the recent one which is described by Pichi et al. So read that OCT classification for astrocytic hematoma, and the shields what they have described about retinal achromic patch. That also sometimes some people have started using as one of the minor criteria for diagnosis of tuberous sclerosis.
Okay.
Good job, Elsa.
Thank you, sir.
Yeah, good job.
Thank you.
Okay.
Okay, Lydia, what of
That's it.
Yeah.
Yeah. I have already informally thanked sir, but still formally, I am making a vote of thanks on this platform for not only for Sir Vishal sir, but also for the scientific committee for coming up with such a brilliant platform for the exclusively for the PGs, benefit of the PGs. And this case, I had a slight doubt whether we should be presenting this case or not, but then I thought we'd go ahead with it because it's a rare topic which seldom comes into the PG discussion in such great detail. So that's why this was taken up, and I'm very glad that we could have this nice discussion here. So thank you, Dr. Bastin. Thank you so much, Dr. Vishal. And Elsa, you have also done a great job. I'm sure that you benefited a lot. Thank you for all for being here on this platform.
Okay. Thank you, sir. Thank you, Elsa. Thank you, Lydia. Good night.
Yeah,
Good night.
thank you, sir. Thank you, madam. I'll be happy to contribute in future. If you have interesting cases, do
Sure.
share with us. Thank you.
Sure, sure.